totally right. And I think all the workup that y'all did, I would have done as well. So yeah, confusional migraine is characterized by an abrupt onset of altered consciousness, and your initial evaluation is really everything that you did. So your serum chemistry is tox, infectious eval, CNS eval, and imaging based on history and physical. And in our case, I think a CT without contrast is reasonable. Okay, so sorry for the super wordy questions, but a 5-year-old girl comes to the ER concerned that her daughter's having frequent headaches, has been more aggressive at school. The headaches don't occur on weekends or during school vacations. While the teachers feel she's a bright child, they report that she's not achieving well at school. The mother is very concerned that there's a serious neurological condition causing these symptoms. When you review the child's medical record, you see that she's been in the ER many times over the past year for very minor illnesses. You note that she was hospitalized at 2 months of age for a viral meningitis. The results of a thorough physical exam, including a detailed neuro exam, are totally normal. The child is kind of growing and developing appropriately. What is on your differential, and what would you do next?
Behavioral disorder?
Definitely.
Depression.
Being bullied at school.
Yeah, no, definitely. Being bullied at school. Someone said depression, like mood type disorder. Anything else?
Lead poisoning.
Lead poisoning, possibly. Is it shooting? Huh? All right.
Mood changes.
Stress, anxiety. Okay, so all these are things to think about. What would y'all do next if you saw this patient in the ER? Discharge? Okay. Anything else? Would anyone do any imaging? Okay, how about any labs?
Maybe a finger stick. I think a finger stick is,
Okay. I don't think that's unreasonable. Sure. Okay. Anything else? All right, so everyone's like, I don't know. Okay. So, of the following, the most appropriate management for this patient is, I'll let y'all read this.
It is proven to be also
A.
A. I heard D, A and D.
I think it would go A
And then D. Okay, so yeah, fair enough. You can write more than one sentence on your dispo instructions, so that's awesome. Yeah, so the answer is A. But D, I think, is absolutely reasonable. I think I would just tell them to follow up sooner than a year. I think that's the kind of thing that, they test you at least on tests. So there is an actual diagnosis called vulnerable child syndrome, which we see often, but we don't necessarily diagnose it as vulnerable child syndrome. So this is when a parent perceives a child as being at risk for illness or harm because of a previous threat, and this perception of risk plus their behavioral consequences of that perception is what make them present to the ER super often. They use healthcare resources very often. They can experience school underachievement. They may act aggressively towards caretakers. And really, I think there's not a whole lot to do from our standpoint other than communicate with the parent clearly that there's probably nothing acutely happening at this very moment. And no labs, really not a whole lot of imaging to do. Someone had mentioned doing a finger stick. I don't think that's unreasonable to do. And just a thorough history and physical. I think if it were me, I would refer to psych. I think they benefit potentially from it. So, is my time up? Cool, conclusion. So yeah, headaches. Well, I just had a bunch of questions. So, did you guys have any questions or anything you want to talk about? Yeah.
Is there anything literature in pediatrics to, I guess, confirm use of like other therapies like caffeine or magnesium that we would use in the adult population? And then have you heard of the use of propofol?
Yes.
In sort of your complex
Yeah, so there is a little bit of literature about propofol and use of ketamine actually, but there's, as far as I know, I think there was a very small study for ketamine, for like low dose ketamine, and I think nothing for propofol, unless I'm getting those mixed up. But you know, it's not the standard of care from what I've read, and most people aren't necessarily comfortable if, you know, I think the rationale is that if you need to start using ketamine and propofol for your headache, I think this is certainly someone that potentially needs to be admitted or needs kind of further work on, from a specialist. And then, sorry, you had mentioned one other. Magnesium? You know what, I didn't do any reading about, I didn't specifically look for anything about magnesium and headaches. I don't know if any of you attendings here know about the use of magnesium and headaches.
specifically in pediatrics.
In pediatrics?
We use it in adults sometimes for refractory sort of migraines, but I don't know anything about this.
In pediatrics? To be honest, I didn't do any specific reading, so I can't say yes or no, but I don't know if Dr. Chow, Dr. Gus.
I don't know anything about magnesium, and going back to the propofol, people have used it, there's some literature on it, but that's very, very uncommon, it's so much later in the management plan, but it is possible. At that point, you probably call neurology, depending on wherever you are, just to get their input, but you've already tried the fluids, the Clairol, the Reglan, the 9 yards, the Excel, whatever you use, and then you get the propofol.
So just a comment on magnesium. So in our ED at UHD, we see the adult neurologist use IV magnesium in our 70, 80-year-old congregant PCD. The rationale is that probably your total magnesium is depleted. There is no right or wrong answer to that. That is the rationale of trying those people who have received other abortive medication and it should not work. IV magnesium is one tool. But the review of the literature that I did just for our fellow conference the other day does not suggest magnesium usage sugar.
Anything else? Cool, thank you guys.